Welcome Dr. Popadic to Osstell, and congratulations to be the winner of our contest. And we want to take the opportunity to have you describe a bit to our viewers and our readers about your background and your experience with Osstell.
Well, my background, I'm a GP practicing dental implant dentistry for now it is 18 years. Yeah, 18 years. Usually I was working with Swedish systems. It's Astra, now it's Noble Biocare. Some other systems in between, you know. Today's market, today's patients, they ask somehow actually on a daily basis even cheaper systems, so you have to just flow with modern demands of our patients. And implant dentistry is not just placing implant and waiting something will happen or anything will happen. You have to follow it, you have to control it, you have to make sure that your patient will get what you really think he should get. So your device is helping a lot in this daily practice, and this the whole treatment from A to Z.
Okay, that's an important aspect. So how do you use the Osstell in your clinic, and in your daily practice, what are the most important benefits that you get from the
Okay,
Osstell?
I'm using my ISQ device so far at the point of placing implant. Of course, I have a torque measurement as well, and then I have the Osstell value. I write it down, of course, and after 2, 3, 4 months, depending what, I do remeasuring, and depending on the value I get, I'm deciding when and how I'm going to load my implants, whether it will be a single unit, sometimes it is really single unit, or I'm going to splint more than 2 implants, depending again on the value. If it's in the lower group, let's say 60 or less, which is not very frequent, I'm splinting them. You have to. If it is above 60, 70, 75, they can also stand as individual units. So I mean, as I said, it's really helpful to just to release me or any doctor using this from the frustration or kind of worrying whether your implant will be able to be loaded at that point, or you have to wait or whatever.
So it provides you with that safety or confidence?
Yeah, definitely.
For
I feel confident when I see 75, wow, or 85, of course.
Yes.
I really feel good.
Yeah. So in your experience, what kind of value are you targeting? Is it 70 or 65 or above?
It's always above 70
yes.
That I'm looking for, but it's not always what I get actually, depending on a lot of morphology details, whether it is a female or male, osteoporosis, stuff like that. So sometimes I have less than 60, but if I have 4 or 6 implants, it's not a big deal. You split them and that will last.
Yes, and that's also exactly in line with all the research that has been conducted on using the Osstell. Have you seen any changes in terms of for you in terms of restoration time or healing times using the Osstell?
Yeah, definitely. As I said, depending on the value I get, I decide whether I'm going to load these implants now when I thought to have them loaded, or I have to postpone it. So my daily practice and the treatment stages are not changed a lot. It may be a few weeks, maybe a month or two, sometimes very rare situations. But we have to adjust our daily practice and single patient stages. We have to adjust it according to the values if you're using it. I mean,
Yes.
That's right.
And before the Osstell, how because then you had like 8 years or so in practice. How did you assess
Challenging torque,
which
is
reverse torque?
yeah, which can be very invasive, and this is what we call to be or not to be.
Yeah.
Amongst GPs, I guess. So challenging torque is something that I usually applied on my implants after having healing abutment for a couple of weeks, and before taking the final impression for the final restoration. I just tried whether it can resist, I don't know, 45 Newton centimeters in reverse direction. So that's it, and tests like, sound, this, what can you do, x-rays, of course, all that usual stuff that doctors years ago were using it. Now with this, what can you, what do you need more?
So when you did challenging torque or reverse torque, how did you feel? Were you concerned?
Not very comfortable. No. Yeah. Even today, I have 2 more doctors doing implant dentistry, and as we have only one device, sometimes it happens that I have and my colleague has the patient for the implants the same stage in the same minute. So I'm using Osstell device. She, for example, do reverse torque, and I know how she feels, because I was using that technique for ages. What I want to say, having this, we just can skip that not very comfortable feeling doing challenging torque on our implant. It's always kind of small dose of fear, I don't know why. We have x-ray, everything looks great, soft tissue looks great. There is no any symptom that could tell you something's going wrong, but still, but with this I really feel comfortable. When this instrument shows me 70 or more, right, I don't need anything else.
Good. So some more questions on are you in your clinic trying to is it important to try to reduce treatment time or protocol time for healing, or is that
well, actually with let's say new surfaces on implants, especially Straumann or Nobel Biocare Astra, first stage of osseointegration has the time has decreased a little bit. I mean, let's say we waited as a classical conventional protocol from Professor Brandmark, right, was telling us for 5 to 6 months in maxilla, for example. Now I usually wait 16 weeks, even sometimes 12 weeks, and it works. I mean, fantastic. I have an implant here, for example, and just I wanted to try. After 12 weeks here, it was in immediate post-extraction insertion. After 12 weeks, the torque was 80. Wow. So it works. Yeah. It really works. So yes, we shortened the first stage, the osseointegration stage. Regarding healing abutment period, I usually leave it for 4 weeks. Maybe it's too long, but that tissue after 4 weeks looks great.
Mm.
Very rarely, if I have a patient from, I don't know, the States or Australia, we have to do it quicker.
Mm.
And if I have to, it is usually in a non-aesthetic zone. I just open it, I wait a couple of days.
Mm.
And usually I open it with a punch. It's not incision, no suturing.
Mm.
So because, the small details that makes your soft tissue look
right
good. But I really try to keep protocols, conventional protocols, applying new technologies regarding surface, regarding values that your device show. I'm trying to shorten the whole treatment, but not without putting in danger anything.
Yes.
I'm not conservative, but I'm not going through the wall.
Right.
I do a lot of immediate function as well. This is already that most of GPs, at least even specialists, consider as risky, not enough researched. But it works all four. It's great.
Yep.
Yeah.
So, but you also do more conventional protocols. One stage, two. You do
I do
pretty much everything.
Definitely.
Yeah. So, in your decision process about the protocol, could you try to summarize how you decide what protocol to apply?
Well, yeah. If I have a scholastic situation, wide bone, lower, upper, whatever, it's very simple. We joke and you just show me the head and I'll do the rest. It's simple, but we have to, not only us, anybody who does this work seriously, we have to look from more than one aspect. It's preservation, whether you need or not augmentation. It's the time, it's the cost, it's the patient's wishes. We are happy when we have our free hands to do whatever we think that should be done. I mean, that's the best. So it's not always black and white. Very low. I mean, they're all colors. I really feel great when I can remodel missing soft tissue as well. Because what is prosthetic in any part of medicine? It's not only replacing a tooth, a white stuff. It's everything around it. So when I have the patient, of course, any diagnostic material is necessary, OPG, CT, whatever we can and we have. And then our way to make a decision how and when depends on what I just told you. Unfortunately, today, patients more and more ask for the price. And it's very difficult to adjust modern protocols with the price. It's very difficult. Very often we do steps that we know it won't be paid, but I feel good because I know it will be okay. Boosting soft tissue sometimes. It's very simple to take the connective tissue graft from the palate, put it there. It'll look better. The patient will not pay because they just can't. But whenever I can, I do it using all these steps that were from the age of Professor Brenmark established. I mean, decision making in implant dentistry is not as simple. A lot of stuff you have to consider.
Yes.
Right.
And once the implant has been placed, so the loading protocol, of course, that's where the ISQ technology.
Yeah.
So have you already decided before, as you place the implant, what loading protocol you want to go with, or does that change depending on on your assessment?
Using your device, making these protocols, these steps, make me more confident. But usually I don't quit my previous idea, whether using this or not. If I have a broken root, for example, without acute infection,
right.
I know I'm going to remove it, and I know I'm going to place my implant right away. And this will help, manual torque as well, value, and this value even more, will help me to make sure that I'm on the right track, that my previous decision was good, you know. I'm not changing a lot my previous idea. This helps me to make sure I'm right, you know.
Okay.
Yeah.
Good. Speaking of your patients, do you treat all kinds of patients also? It sounds like you're treating all kinds of patients.
Yeah.
Even, you know...
my oldest is 94 with 6 implants.
Yes.
94.
The last
a huge Italian guy.
Yeah. So you don't refer any patients to other clinics? Or
no, I don't need to. We really, myself, the most part of it, can do any part of surgical and prosthodontic treatment.
Good.
In our clinic, yeah.
Yeah. So, and when it comes to risk patients, do you see that the results, the ISQ measurements, do you have to wait longer, or what's your experience?
Okay, risky patients.
Or compromised bone. That's
compromised bone. The patients which I can place in a risky group, let's say.
Yes.
Where I still decide to do implant dentistry are usually women with osteoporosis. Anybody else who is compromised in like systemic diseases, heart issue, whatever, we usually do not treat them. For example, patients with heart issues, we really need from the cardiologist approve to continue. If he or she says yes, you can, of course, depending on a lot of those factors, yes, we do. But all other patients where we really can expect problems, we don't treat them. I think it's not only us, it's anybody who does serious work. And talking about compromised bone, like osteoporotic bone, yes, we do, without any problem. Even we treat, it's again usually women after 55 or 60, using bisphosphonates. If it's oral, not intravenous, we treat them. We treat them. It's surgical part of the treatment has to be minimum invasive, has to be, and this is also instrument where a situation where this instrument helps a lot, especially when you know and when you see before even starting there's a soft bone. There are surgical techniques that you have that you can make these bones dense, more dense, but this helps a lot, whether I'm going to load it right away or wait or postpone it or whatever. But we do, we don't exaggerate, definitely.
Good. So if we go back in time, what to your first 5 or 8 years in practice before you had the instrument, what would you tell someone today that is in the situation you were back then?
It's easier today.
Yes,
it's much easier today to make sure that every step of your implant treatment will go just fine, without having fear, without feeling yourself uncomfortable. But there's also the other side of the coin today. A lot of younger colleagues, I think they just rush into implantology without enough knowledge. But what can you do? This is something which where the rules or whatever the institutions cannot do a lot. I mean, it's just depending on yourself whether you think you should go into this, whether you have plan B or not. You know, these stuff helps, what I want to say, even non-experienced colleagues to move on. Maybe this could create sometimes a false security. And this is the point where devices like yours must have in a wider population, speaking about doctors, more scientifically based, you know, details, knowledge, whatever. So it's very important you spread the story, the scientific part of this, which stays behind, into the population.
Yeah. I'm glad you say that, because it's been very important to us that there's more than 700 publications.
Sure. That's very important. Yeah.
So coming back to patients, do you communicate around the ISQ with the patients? Do you explain it to them?
Yeah, sure. At least they always ask, "What's that sound? What are you doing, doctor?" You know, we have the camera, and they can see themselves on the monitor as well. You know, what is? Yeah, we explain to them, and they feel just, you know, they feel great when I tell them, when I show them, for example, look, it's 80, 85. Wow, you know, that's
yeah,
that's great.
And what do you think will happen with implant dentistry over, say, the next 5 years or so?
Well,
what are the most important trends, you know, for you think, and for your colleagues?
It's always shortening the time, but it's something that our patients have put on our back. I would say. Now it's up to us whether we are going to fulfill our patients' wishes at any cost. I don't think we should do that. It's always time, it's always price. I don't know what should and what could happen that could impress me, or, you know, people, as for example, this device impressed me years ago. I guess something will happen, but this is somehow we have everything we need from the material point of view, from the device point of view, from the technology and techniques, surgical techniques point of view. Everything we need for excellent implant practice.
In your, professionally speaking, you know, as a dentist, and now involved with implant treatments since a long time, who or what has inspired you most, professionally speaking, if any?
Well, definitely Professor Brandmark. I mean, it's not just a story behind us doing dentistry, the implant dentistry, but he's the person. His enthusiasm that were lasting for decades. I think definitely he inspired me. But also the guys like Daniel Boozer, like Moy, yeah, they are. I mean, I watched them live, you know, and I was in some workshops with them in LA, in Bern. They are the guy who definitely will lead implant dentistry in the right direction. So they are the guys who can impress anybody, not only me. That's my opinion.
Excellent. Thank you very much, Popadic.
You're welcome.